So I'm John Webb. I guess I'm the sole moderator this morning. We just have a fabulous faculty. I'm looking at Greg Stone and Marty Leon and David Cohen and Alan Yeung from Stanford and Dr. S.J. Park. And we're going to have a few probably very impressive lectures. First of all, maybe we'll go ahead with Marty. Do you want to go ahead, Marty, and tell us about the aortic valve and your journey?
Thanks, John. Well, this is it's wonderful to be back at TCT Asia Pacific, even if it's virtual and online. This is a daunting topic, so I'm going to have to be selective. They've asked me to speak about the long TAVR journey, a chain of RCTs, guideline changes, and future directions. These are my disclosures that are relevant to this topic. I begin, as I usually do, by crediting my friend and colleague, Alain Crebier, who truly was a first-in-man pioneer. This is 15 minutes after the first TAVR that was done without general anesthesia, without transesophageal echo, in a desperately ill man with bicuspid aortic valve disease and an ejection fraction of 10% and no femoral access. After successfully concluding this proof of concept case, we had a phone conversation, and his only question was, okay, what now? Well, that was back in 2002. I would argue that the TAVR revolution was not a random event, that it was the inevitable result of decades of what were bold progressive iterations in surgery, cardiac imaging, and transcatheter therapies. But I think no one could have predicted that we would see such a rapid technology evolution in TAVR. We'd see so many procedural refinements and simplification, an avalanche of clinical evidence, the acceptance of the heart valve team, all resulting in a dramatic reduction in complications and improved outcomes. These are some of the current standard TAVR systems in the United States and elsewhere, as shown here, but there certainly is an impressive evolution of technology that's occurred over the course of a little more than a decade in this space. Not to mention the many accessory devices that have been developed to be able to facilitate performance of this procedure and to make it generalizable, efficient, and safe. This concept of procedural refinement is terribly important, what we now call the minimalist strategy, which means that we most often don't use general anesthesia or transesophageal echo, that we favor percutaneous transfemoral access, minimize the post-procedure details so that we can take patients without ICU admissions, monitor them in recovery areas with rapid ambulation and early discharge. I would say that worldwide, most patients are candidates for some version of this minimalist approach, and the median length of stay now in places like Colombia and throughout the United States is only 1 to 2 days. This is just a listing of 24 randomized trials that have been completed or ongoing in the TAVR space that run the full spectrum of those patients with extreme, high, intermediate, low, and even asymptomatic patients with aortic stenosis. So a mass of clinical data. Over 15,000 patients enrolled in just FDA studies, including 10 randomized trials with multiple generations of 4 different TAVR systems. Just within the balloon expandable space in the United States, the partner trial phenomenon has spanned 9,000 patients with 5 randomized trials, which has resulted in more than 200 peer-reviewed manuscripts and abstracts thus far. And of course, this concept of the heart team, which really integrates the many different physician and non-physician components of the caregiver team, has been essential to the success of TAVR. And now the patient is really being placed in the center of this with shared decision-making concepts to be able to improve their involvement as we make decisions. All of this has resulted in a dramatic change in complications. You can see the mortality of the first partner trial, 6.3% at 30 days. In the partner 3 trial, it was 0.4%, a 15-fold difference in mortality. Yes, in part related to the kind of patients we treated, but many other factors contributing to this. So all of this has resulted in a dramatic change in the guidelines, with many class 1 recommendations for patients based upon multiple randomized trials with many different systems, self-expanding and balloon expandable. But I would also argue that much of the early work in TAVR involved the minority of patients with aortic stenosis, and it's only been relatively recent that we've really encountered the mass of patients who are surgical candidates who have severe symptomatic aortic stenosis. So the high and intermediate risk patients probably comprise about 20% of the total population of operable patients. So the holy grail is the 80% of AS patients receiving surgery who are in the so-called low-risk category. This is the cappuccino symbolism. Depending upon where you are, there's another way of expressing this, but the reality is we need to get to the core of the data. And this had been a goal that was recently undertaken over the past several years and culminated in 2 manuscripts in the New England Journal of Medicine in the spring of 2019 with both balloon expandable and self-expanding devices. But I want to argue that there have actually been 4 randomized trials with a total number of 3,661 patients, 2 in the United States, but also the earlier Notion trial and the UK TAVR trial, which is not even yet published yet. So this has certainly been a global effort to really understand how low-risk patients respond. Starting with the Evolute low-risk trial, which is a 1-to-1 randomization using some very interesting Bayesian adaptive statistical design concepts. They looked at a large number of patients who were truly low risk with a 1-to-1 randomization and demonstrated clearly that there was no significant difference between surgery and TAVR in the first year, with event rates of 5.3 and 6.7% respectively. And the primary endpoint was death and disabling stroke. No change in mortality, a reduction in heart failure hospitalizations, and certainly no change and a reduction looking at these Kaplan-Meier curves over the first year of disabling stroke. If you look at this as a stacked bar, you can see that there appeared to be a difference favoring TAVR versus surgery. And importantly, the hemodynamics were not only as good, but appeared to be better than surgical valves out to a year with very careful analysis of serial hemodynamic measurements. Similarly, in the PARTNER 3 trial, 1,000 patients randomized 1-to-1 with follow-up at a year using a triple endpoint of death, stroke, and rehospitalization, showing what appeared to be not just non-inferiority, but superiority of TAVR versus surgery in these low-risk patients. With, interestingly, looking at the combined death or disabling stroke endpoint, only 1% event rate at a year that was significantly less than surgery in this trial. So if we were to look at the clinical care pathway from this study, you would see that these patients were admitted same day. 3/4 had no general anesthesia. It's a femoral artery puncture. The procedure was less than an hour. 3/4 of the patients were transferred to the floor, and 96% were discharged to home or self-care. With rare procedural complications, the 30-day mortality was 0.4%, less pain, bleeding, acute kidney injury, and post-procedure arrhythmias, improved early recovery from the standpoint of quality of life assessment, and a 1-year mortality of 1% and serious stroke rate of 0.2%. These are striking outcomes. And it caused Eugene Brownwald, who was a panelist at these ACC presentations, to mention that this was an historic moment, and all of us here should remember it as such. It really did represent what we thought was a paradigm shift in the way we manage patients with severe aortic stenosis. Now, this is still embargoed. It'll be published on Monday, but these are the 2-year outcome data that you'll see in JACC from the PARTNER 3 trial. We don't have time to discuss all of the data, but this is the central illustration from that JACC manuscript showing that there was still a very significant difference in this triple composite endpoint out to 2 years, but some narrowing of the death and disabling stroke endpoint out to 2 years, still favoring TAVR, but pointing out the significance of a late follow-up in these patients, because the story is not over at a year. We also looked at quality of life, and this categorical ordinal analysis showed that even in these low-risk patients, that out to 2 years, that there was a significant benefit associated with TAVR compared to surgery. So the favorable outcomes of TAVR have been consistent now across an entire surgical risk spectrum, suggesting that surgical risk estimation probably should no longer be the primary basis to guide the choice between TAVR and surgery. But the caveat is that many patients, at least 30%, were excluded from these low-risk trials. We don't have time to review all of it, but many patients were not included, including patients with bicuspid disease, patients with very small or large annuluses, multi-valve disease, high-risk TAVR anatomy. So these trials apply to the patients who were enrolled, not everyone. But there should be a shift from surgery first to a TAVR first strategy for most AS patients. The heart team will have to weigh clinical and anatomic characteristics, identify best treatment options for individual patients, with transfemoral TAVR replacing surgery as the default therapy in at least many, and I would even argue most cases. So what we're seeing is a paradigm shift. The conversation is changing. Initially, we talked about using TAVR in patients who do poorly with surgery. Now we talk about using TAVR in patients who we think would do well with TAVR as the first process. Now, all of this has led to what is now the newest guideline change. This has just come out, and these are really fabulous guidelines that the ACC and the AHA have put together. So I'm really impressed what they've done. This is a summary. It's a very complicated slide, so I'm not going to go into the specifics, but I will simply mention that this helps to understand how you decide which patients might get surgery or TAVR. First thing I'll point out is that now high and prohibitive risk are viewed in the same way. And TAVI or TAVR is viewed as the preferred therapy in high or prohibitive risk if they fulfill these criteria. As well, in those patients that where it's appropriate to have a bioprosthetic valve, there are three other class 1 indications for using TAVI, either as a preferred or alternative therapy to surgery, to a large extent based upon age and a variety of other clinical and anatomic factors. So these guidelines are very interesting, and they bring the TAVR age down to 65 for the first time as being an alternative to surgery. Now, buried in the data supplement of these guidelines is a very interesting analysis looking at the absolute effect estimates per 1,000 patients for outcomes, comparing TAVI to surgery. And I found this an interesting analysis, and I've shaded in blue the areas that favored a TAVI. So mortality at 2 years across all age spectra favored TAVI. Life-threatening bleeding, atrial fibrillation, acute kidney injury, all favored TAVI versus surgery. But also aortic valve reintervention, both at 2 years and 10 years, and a permanent pacemaker rate, and moderate or severe heart failure favors surgery. So these are the kinds of things that need to be communicated to patients, and physicians need to understand as they're making decisions about one therapy versus another. Well, I'm going to conclude by talking about future directions, and I'll do this as quickly as I can. There's so much new going on in this field. There are still many knowledge gaps. Many people think that the evolution of TAVR has plateaued. I think that's wrong. The issue of cerebral embolic protection to reduce strokes, should it be used systematically, selectively? Many different views on this. There's one approved device in the United States, other devices that are in clinical trials. We did a pivotal clinical trial that did suggest that 72-hour stroke rates were significantly reduced, but it really wasn't powered to show clinical endpoints, and it missed its primary endpoint. There have been multiple other small randomized trials, the meta-analysis of which does suggest that there may be a stroke benefit, but without question, we need more data really to understand whether or not embolic protection should be part of the procedure. The importance of valve leaflet thickening, as discerned by CT studies, and valve thrombosis, which is more of a clinical diagnosis, needs to be clarified. A lot of interesting work done by Raj Makar and his group, sub-studies from clinical trials. This happens to be the sub-study from the Partner 3 trial involving 435 patients with serial CT studies, indicating that there's a high frequency of HALT, which is hypoattenuation leaflet thickening, that in 30 days was greater with TAVI than surgery, but equalized at about a year. Interestingly, looking at the natural history of untreated patients, half of these patients who have 30-day evidence, it goes away by a year without any treatment. And about 20% that didn't have anything at 30 days develop it at a year. So this is still a phenomenon that needs to be clarified. Generally is asymptomatic, most often does not cause hemodynamic changes. Even those with the most severe HALT have some but not major changes in echo parameters, including mean gradient. And so far, the clinical associations have been weak with these CT observations. Bioprosthetic valve durability is a big issue, and there are new definitions that I want to make sure people understand. The original new definitions from EACTS and ESC have now been further clarified in VARC 3. And analyses are being done now indicating that at 5 to 8 years, even using these new definitions, the event rates for what we call durability or severe structural valve deterioration or bioprosthetic valve failure are quite low, but these are not large enough data sets to make definitive conclusions. But I would argue we need these definitional standards to be used. The safety and durability of a TAV and TAV procedure and the safety of failed TAVR surgical explantation needs to be understood. This is going to be a whole new field that we're going to be developing over the next several years to better understand. And John's group has really made seminal observations in this area. Issues relating to coronary access, especially in patients with coronary disease and younger patients, is very important. So we need to better understand issues of commissural alignment and coronary access in the future. The management of post-TAVR conduction disturbances is especially interesting. We focused on new pacemakers, but I'm going to refocus you on new left bundle branch block. This is an analysis done by Tamim Nazif and Joe Dizon of 3,000 partner 1 and 2 patients. And in those patients with new left bundle branch block, it was strongly predictive of a variety of very adverse clinical outcomes, much more so than whether or not a patient got a new pacemaker. So we need to really address this issue of how to manage these patients. Optimal antithrombotic pharmacotherapy is poorly understood. The recent popular TAVI study indicated probably the dual antiplatelet therapy makes no sense, and that looking at key endpoints of all bleeding, non-procedural bleeding, and CV mortality, and non-procedural bleeding, there's no question that the standard should not be dual antiplatelet therapy in TAVI. Severe AS in the setting of concomitant disease needs to be explored. There's a massive trial, and John is one of the key architects of this with David Wood, the complete TAVR study, one of the largest trials ever done, 4,000 patients just beginning looking at complete revascularization in patients with concomitant coronary disease. And the Watch TAVR trials completed enrollment. It's an AS and AF study looking at the Watchman device versus medical therapy in these patients. The management of bicuspid disease is a completely new area. This is certainly important in Asia, and it's very important in the US. There are essentially no good randomized trials. There are some new registries, this one using the Evolute device in low-risk patients, showing very good outcomes, good hemodynamics, and not much in the way of paravalvular leak. And a parallel study, which was done as a registry as part of the Partner 3 trial that Matt Williams and John Webb led, showing equally good results from the standpoint of clinical outcomes and very low paravalvular leak rates as well. But these are only registries. We need more data. Asymptomatic severe AS and symptomatic moderate AS are new exciting subgroups. The early TAVR trial is almost completed with enrollment, believe it or not, and the Unload trial in moderate AS and heart failure is continuing, with other moderate AS trials planned and on the verge of beginning in 2021, in part based upon some interesting data out of Australia suggesting that there's very poor long-term survival in patients with untreated moderate aortic stenosis. And finally, the life journey of these patients with aortic stenosis, particularly in younger patients, needs to be better understood and is going to be a future area of interest. There are new devices like this aortic valve remodeling device that may, if not supplant, may complement the use of valve replacement to extend natural valves without requiring replacement at a young age. And this concept of sequencing to make a decision about which therapy comes first, I think is going to be extremely important, will involve shared decision-making, and particularly relates to the intermediate age group, where we're simply not sure which procedure should be offered first. So to conclude, these patients are amazing. This is the first patient we treated at Columbia who was 92. He had critical AS, could not walk across the room, and within 30 days was playing golf in Palm Springs. He lived for about 5 years and died of a concomitant cancer. But we learned quickly how extraordinary these patients are. Scroll forward. This is a patient that was taking care of one of my colleagues, former fellows, Philippe Genereux, who was admitted in the morning that day. He's a man in his 50s with Hodgkin's disease. Who had chest wall radiation and was not a candidate for surgery. And he left the hospital the same day at 5 o'clock, the first outpatient same-day TAVR that was performed, just showing how far we've come over a short period of time. And then to conclude, yes, this is all about the patients. I've tried to describe for you a long journey, and this is one of our favorite patients that I often show. This is a woman celebrating her 100th birthday. Couldn't change all of her habits, but this really is about the patients. And we're really struck by the great benefit that TAVR has provided for so many hundreds of thousands of patients, approaching 1 million patients treated, possibly by the end of 2021 with this new therapy. Thank you very much.
Well, thank you very much, Marty. That was stunning. Marty, I just want to ask you, so, you know, the surgeons asked me, somebody asked me recently, they had a surgery in my program. So, John, at what point are TAVR and surgery going to cross over? You know, in partner 2, you know, 2 years, there's some reduction in the relative benefit. Where do you think we're going with this? What do you anticipate in the next few years?
Well, again, it depends on what we mean by crossover. I don't have any reason to believe that the primary endpoint events are going to necessarily cross over. You know, I think that the two therapies are, you know, essentially equivalent, I think, in some of the major endpoints. We don't know if there's going to be a durability difference. There's no question that, you know, there are some differences in valve performance as it relates to paravalvular leak, and that may translate into later outcomes that won't be as good from the standpoint of structural valve deterioration. But that's going to likely be a 5 to 10 year phenomenon. We have not seen any striking early signals of early valve deterioration, although I think that there's some circumstantial evidence that there may be a quantitative difference in longevity of these valves. But I think, you know, we can still, I think, manage that in several ways. But if there's going to be a crossover in terms of durability, it's probably going to be beyond 5 years and maybe closer to 10 or more years.
Mm-hmm. So I'd encourage any of the rest of the panelists to jump in and ask a question. Yeah, sure, Alan.
Marty, a stunning talk as usual. So you showed the 2-year data for the low risk group, right? So there is in the stroke, there's some catching up from 1 year to 2 years. I know the numbers are too small since it's 1% to 2%. What do you think could be the mechanism, or could be just obviously, you know, statistical variance in it?
You know, we all do We all know doing clinical trials is exciting. There's always unexpected things. There was a catch up in mortality. The entire difference was cardiovascular mortality. So those were more random events, we think. There was a catch up in strokes, and 2 of the strokes related to patients that were diagnosed with valve thrombosis, and that may have been more real. I would again say that, that was using an earlier definition of valve thrombosis, but still, those are things that we look for. It is interesting that in most of the other studies we've done, we've never really seen a catch up between 1 and 2 years. And the event rates are so low that it's just a little bit hard to know how meaningful that is. And is that a trend that's going to continue over time? We should have the 3-year data soon, and it'll be very interesting to see if those trends are going to continue.
Yeah, I would just add to that, again, when we look at these curves, and your surgeon, John, is making this point, is that we act almost as though those curves have some momentum to them or something like that, that there's, the fact that the curve is going in one way between 1 and 2 years means anything about what we're going to see between 2 and 3 and 3 and 4 and 4 and 5. And they simply don't have momentum. And it's a common misperception when people look at these kind of data and make those sorts of inferences. So I think, the conclusion at 2 years is no difference in death or stroke. That's the solid conclusion. And 5-year data will be interesting, and 10-year data will be interesting. But but drawing conclusions from the 1 to 2 year trend leads to a lot of problems and misinterpretation.
So, Marty, in my center, we sit in a group and we talk about these patients, and it's clear that some of our surgeons believe that if you're under 70, surgery is the default. And others think maybe, 65 might be a reasonable cutoff. And I think in the current guidelines, 65 seems to be some magic number. What do you think about this? We have people coming to see us who are 50 and they don't want to take time off work. They're happy to reconsider some second procedure in 10 years. What do you think about the age cutoff for surgery versus TAVR in a very general way? I need a number to write down, Marty.
I think it's a good point, John. In the low-risk trials, we didn't treat very many patients under the age of 65, even though there was not a lower age cutoff. So we didn't have very much data. And in fact, I was surprised that the guidelines committee went down as low as 65 in terms of recommending that TAVI and surgery were non-inferior. And I asked the committee, and they presented some reasonably convincing data from a variety of data sets suggesting that it was legitimate to go down to 65. So I feel pretty confident about going down to 65 and saying that the two are equivalent. There are so many other factors to consider, though. As you said, it's patient expectations, it's patient activity, it's concomitant disease, it's a whole variety of things, and it's your belief in this sequencing concept. If you start with TAVR, under the age of 65, in somebody with an extended life expectancy, they're going to have a second procedure. You're going to have to be thinking when you put it in, what you're going to be doing next in these patients. So I think that as you talk to patients, you can't just be talking about the primary index procedure, but what the next procedure is and trying to make that decision. My feeling has always been, John, that nobody should have more than one operation during the course of their life. So the question is, when do they have that operation? So I would prefer to consider TAVR early and reserve the one operation for later in life, and expecting they're going to end up probably having 3 procedures over time, where hopefully only one of them would be open surgery. But this is open for debate too.
So maybe we should move along. So, it was news to me and quite a surprise when I found out that after we were working on the aortic valve for a while, that there's also a mitral valve there. and Gregg Stone, I guess, is now written in stone the definitive early trial anyway with COAPT. And do you want to go ahead and tell us a little bit about this new valve, Gregg?
Thank you. And actually, to my great surprise, I learned there was a tricuspid valve. Okay, so you should be seeing my screen now. So SJ asked me to speak about transcatheter mitral valve repair, guideline changes, evidence gap, and future directions. And these are my disclosures. So, you know, I'm always jealous of my colleagues that treat the aortic valve because it's a relatively homogeneous disease, and it's a relatively straightforward pathophysiology. The mitral valve, as everybody knows, is much more complex. There are many etiologies of mitral valve degeneration, and we can simply, though, break it down into primary MR, where the problem is the valve or the supporting valvular structures, and secondary mitral regurgitation, where the problem is actually either the left ventricle or, in occasional cases, the left atrium, which then causes either geometric disturbances to the papillary muscles or the annulus and causes secondary mitral regurgitation, where the leaflets themselves are normal. And we can always bring this back to the Carpentier classification. And this is still really very relevant to the way both surgeons and I think interventionalists think about treating mitral regurgitation today. With primary MR, we can think of Carpentier type 1, where there's basically a degenerative or morphologic problem in the leaflets, such as clefts or perforations. Carpentier type 2, where there's excessive leaflet motion, usually from prolapse, whether that's due to fibroelastic deficiency or Frank Barlow's disease. And Carpentier 3, where there's restricted leaflet motion in either systole and diastole. Secondary MR, as I mentioned, is, again, the valve is relatively normal until late in the disease. There may be some fibrosis, but about 90% of this is caused by left ventricular dilatation from heart failure with papillary muscle dislocation and tethering of the mitral leaflets due to restriction from the dislocated chordae. Now, the standard of care has always been surgery for mitral regurgitation. And, you know, the surgeon have tremendous advantages by being in there and being able to diagnose the exact both morphologic and degenerative changes in the valve. We can predict many of those by imaging, but the surgeons, again, have the advantage of seeing it. And there are many established techniques and newer techniques that can address the annulus, the leaflet, the chordae tendineae, the papillary muscles themselves, often with either a standard or undersized annuloplasty ring. And being able to tailor the kind of treatment for mitral regurgitation leads to an extremely high rate of surgical repair. For degenerative MR, it should be over 99% with an excellent mitral valve surgeon. So despite this 30-year history of mitral valve surgery and the fact that for primary or degenerative MR, a surgery repair is clearly the standard of care, it's striking that we have no randomized trials to actually demonstrate that. Nonetheless, we have a lot of observational studies to show that in patients with primary or degenerative MR, that after successful mitral valve surgical repair, the patients are placed back on their expected age and sex match trajectory in terms of both survival and freedom from heart failure. Now, in contrast, in patients with secondary MR, where the problem is primarily heart failure due to left ventricular dysfunction, we really don't have any evidence that surgery makes a major impact on the natural history of that disease. Again, there's no randomized trials. So most of the data we have is observational. And this older study is still the one that is most widely quoted, led by Steve Bowling at the University of Michigan, one of the leading mitral surgeons, looking at patients with heart failure, 3 to 4 plus MR, and ejection fractions less than 30%, being treated either with medical therapy or surgery, and absolutely no difference in overall prognosis. And in fact, if anything, because these patients have multiple comorbidities, they're older, surgical mortality is not trivial. And for this reason, surgery, isolated mitral valve surgical repair, which is usually just an undersized rigid annuloplasty ring, is rarely performed. So if you look, for example, from the STS registry in the United States of 87,000 mitral valve operations, only about 4% of them are for functional mitral regurgitation. That's about 700 patients per year in the United States, which is absolutely nothing. So the standard of care for secondary mitral regurgitation due to heart failure is really guideline-directed heart failure medications, which in some cases will lead to reduced left ventricular dimensions and therefore reduction in secondary MR. So this is where transcatheter mitral valve repair may have a role. And as you know, we now do have some randomized trials, and the randomized trials we have are with the transcatheter edge-to-edge repair with the MitraClip. You're all very familiar with this device. It replicates the original alpha area surgical suture-based repair in which you perform a double orifice where you're creating a double orifice by basically clipping the anterior and posterior mitral leaflets together and therefore reducing mitral regurgitation. So the first mitral valve randomized trial ever, really strikingly, was instigated by this device being available for its approval, and this was the Everest 2 randomized trial. These were low-risk patients, 279 of them at 37 sites. And this was done now, as you can see, started almost 15 years ago. And at that time, we didn't even realize how different degenerative MR and functional mitral regurgitation were. So they were just grouped together, and about 3/4 of the patients had DMR, a quarter had functional MR. These were in the early learning stage period of the MitraClip, and they were randomized to either the MitraClip or surgery. So again, at this time, even the FMR patients were treated with surgery. And as we know, there was primary safety and effectiveness endpoints, and not surprisingly, the MitraClip was much safer than mitral valve surgery, in particular because of reduced transfusions, But there were also slightly fewer strokes and 1 or 2 less mortalities. But in terms of effectiveness, the MitraClip was not as effective as surgery. In particular, in this very early learning phase, the ability to get mitral regurgitation at 2+ or less was only about 76%. And there was a slightly higher recurrence rate requiring mitral valve surgery and reintervention. Even though the survival and freedom from stroke was similar, overall the effectiveness was just not there. And as a result, mitral valve surgical repair stayed as the appropriate therapy, particularly for patients with degenerative mitral regurgitation. However, when they looked at the subgroups within this study, and you got to be very careful, it's a small study, but nonetheless, there was only one subgroup that actually stood out. And that was whether or not, interestingly, the patients had functional or degenerative MR. And if the patients had degenerative MR, then they clearly did better with surgery. But if the patients had functional MR, then there was no significant difference in outcomes, even effectiveness, between the MitraClip and surgical repair with a ring. Although I will point out that the confidence intervals are wide, and since surgery was never proven to improve outcomes in functional MR, this could either mean that the clip is as good as surgery, or neither of them are beneficial at all. So on the basis, though, of this trial, which was really disappointing, there was an associated registry with the study that showed in high-risk patients at least received symptomatic benefit from the MitraClip. These were patients at prohibitive or extreme risk for mitral valve surgery. And so back in 2013 in the United States, the FDA approved the MitraClip for treatment of symptomatic patients with severe degenerative MR who are at so-called prohibitive risk for mitral valve surgery. And in the United States, because that's how reimbursement followed this approval, the vast majority of patients that were treated with the MitraClip were treated for degenerative MR in patients who could not undergo surgery. And this is what was reflected in the guidelines. This is actually the most recent 2020 focus update of the expert consensus decision pathways for how to treat MR. Here's primary MR, symptomatic MR. I won't go through this in detail, but basically if you have symptomatic severe MR at a patient prohibitive risk for surgery in whom you think you can get a good result with transcatheter approach, this is really the MitraClip. Then with a class 2B level of evidence B based on the registry data, TMVR may be considered. Now, since the Everest 2 trial, obviously the results of the MitraClip, because of increasing operator experience, have gotten much better. And now effective repair rates can be expected in greater than 95% of patients with degenerative MR to at least get down to less than or equal to 2+. And of course, this is an extremely safe procedure. So this has led to the thought that now we should be able to offer this therapy to patients with lesser surgical risk, perhaps not low surgical risk patients with degenerative MR, but maybe those at intermediate risk or moderate risk. And there is a 500-patient randomized trial ongoing now called Repair MR. And these are patients who either have NYHA class 2 to 4 symptoms or even are asymptomatic with evidence of early left ventricular dysfunction or pulmonary hypertension, similar to the surgical guidelines. And with moderate surgical risk, very interestingly, being defined as any patient greater than or equal to 75, or if less than 75, those with an STS a repair score of 2% or greater for mortality or other individual surgical comorbidities. And these patients are randomized to the clip versus surgery. Interestingly, follow-up is for 10 years in this study, so that's the first time we'll see that. And the primary clinical endpoint is the composite of mortality, stroke, rehospitalization greater than 30 days after treatment, or acute kidney injury requiring renal replacement therapy. There's also a primary echocardiographic or mitral endpoint, if you will, which is basically looking at success and of particularly trying to achieve 2+ or less mitral regurgitation without mitral valve replacement or recurrent procedure. So this trial is ongoing, but enrolling slowly. Now, when we get to functional MR, where the disease is the left ventricle, either from usually ischemic or idiopathic dilated cardiomyopathy, these are probably about twice as common cause of mitral regurgitation compared to secondary MR. And of course, here we have the COAP trial, which is the largest randomized trial to date in 614 patients with left ventricular ejection fractions of 20 to 50%. Who were symptomatic with severe secondary MR. And then once they remained such, despite maximally tolerated guideline-directed medical therapy, they were randomized to the mitral clip versus medical therapy alone. And you know the results of this trial. There was a marked reduction in heart failure hospitalizations within 24 months, about a 50% reduction. This was the primary endpoint. This was really beyond a shadow of a doubt, with the number needed to treat of only 3 patients to prevent a heart failure hospitalization. In addition, mortality was reduced. And mortality, unlike heart failure hospitalizations, you could see took a while to be reduced. The curves don't start diverging for about 9 to 12 months, most likely going along with the chronic effects of reduced left ventricular volume overload. But then the curves are diverging over time. And you can see at 2 years, there's an absolute 17% reduction in mortality. So this is the number needed to treat of 6 patients to save 1 life. And if we try to put this into perspective, if you look at all the heart failure medications that have class 1 guidelines, and you look at the number needed to treat to save a life within 2 years, these are beta blockers, ACE inhibitors, Entresto, et cetera, it's usually about 20 to 50 patients. In addition, in contrast, if you look at the HFrEF patients, that is an ejection fraction less than 40% in COAP, despite being on all these medications, it only took 5 patients to save 1 life. So this is incredibly highly effective therapy in the impact it can have to our patients' lives. In addition, reducing volume overload with the mitral clip reduced progression of disease as reflected in the need for either LVADs or heart transplants. And this is one of the safest procedures that we do in the cath lab. And again, the operators have a lot of experience doing this now. And if you look at the freedom from major procedure-related events out to a year, it was 96.6%, which is well above the 88% objective performance goal. What underlied all of this benefit was the marked reduction in mitral regurgitation. And again, in 93% of all the patients, including 95% of those treated, the MR was brought down to 2+ or less, with now about 3/4 of those being 1+ or trace. In contrast, at 30 days, you could see some of the medical therapy patients, interestingly, had their MR reduced from 3 to 4+ down to 2+ or less. And this really goes to the dynamic nature of functional mitral regurgitation. If you looked at the impact of the MR reduction at 30 days to long-term outcomes, this is at 1 month. And if the MR was reduced to either 1+ or less in the green curve, or 2+ or less in the blue curve, then you have a reasonable outcome in terms of death or heart failure hospitalization. But if the MR was not reduced to 3 to 4 plus, as you might have expected, then you've got a much worse prognosis. And we were not able to show a difference between 1 to 2 plus MR. The curves may be a little bit different, but not statistically so. And perhaps most telling, if you look at the MitraClip arm and the medical therapy arm, these curves look almost identical. So it really doesn't matter how you reduce the MR, it's the reduction of MR, whether it's medical therapy, whether it's MitraClip, and I'm sure it's other devices or surgery as well, as long as you can do it safely. Now, we do have another trial, as everyone knows, and that's the MITRA-FR trial, which on its face looked relatively similar. It was about half the size, 304 patients, and done in France. And in contrast to COAPT, MITRA-FR was absolutely negative in terms of reducing death or heart failure hospitalization, whereas COAPT was very positive from day one. So what were the differences? And there's been tremendous speculation to try to understand these differences. The biggest difference is probably what Paul Grayburn and Milt Packer have described as being the differences in the relative severity of mitral regurgitation relative to the size of the left ventricles that were enrolled in these two studies. And I thought I would take a minute or two to explain this because there's a lot of misconceptions about this. If you look here from the Gorlin equation, there's a relationship between the left ventricular end diastolic volume and the effective regurgitant orifice area when you're trying to assess severe mitral regurgitation. So this blue line would be a regurgitant fraction of 50%. Most people can agree that's severe MR. And as you can see, as you go to larger and larger ventricular sizes, you need a higher and higher effective regurgitant orifice area for that to be severe. Now in COAPT, these are mean values, and you can see this was the size of the left ventricle in COAPT, the mean left ventricular end diastolic volume, and the mean ERA, which was about 0.41 centimeters squared. And as a result, you could see that the average patient in COAPT was way above this line, in a category that Grayburn calls disproportionately severe MR, that is more than just standard severe or proportionally severe. MITRA-FR, on the other hand, had much larger ventricles and lower degrees of mitral regurgitation, so they were actually on kind of the borderline of being severe and non-severe. So basically, disproportionately severe MR is very severe MR. That's severe MR, and this is non-severe MR. Very severe MR would really be expected to greatly benefit from MR reduction. Severe MR would also be expected to benefit. Non-severe MR, not so much. Now, of course, there's a cloud of patients around each of these means. And it's been impossible to be able to look at the individual patient and to be able to try to predict whether they're going to benefit, because there's so many other parameters, including loading conditions, left atrial pressure, specific ejection fraction, et cetera, that goes into this equation and other models as to whether the patient will respond. But I do think this model does hold. So 3 patients here, for example, with an EROA of 30 millimeters squared, one with marked LV dilatation, one with mild to moderate LV dilatation, and one with normal ventricular size. This patient is likely to benefit only from an LVAD or transplant. This patient is going to benefit from mitral regurgitation correction. And it just so happens that MITRA-FR enrolled more of these patients, COAPT enrolled more of these patients. And this was not by chance. This is because in COAPT, we really very carefully put in inclusion and exclusion criteria to, 1, exclude the largest left ventricles, those with an end systolic dimension greater than 7 centimeters, and 2, require severe MR from a multiparametric approach. How did we do it? It's complicated, but 86% of the patients got in with either an EROA of greater than 30 millimeters squared or pulmonary venous systolic flow reversal. All 3 of the tiers that allowed patients into COAPT benefited, but if you can remember that, that's most of them. In addition, we again capped the size of the left ventricle. That's very important, to 7 centimeters, and we also excluded patients with very severe pulmonary hypertension or RV failure. So the bottom line on the basis of this, last year, the FDA approved the MitraClip for the treatment of functional mitral regurgitation. I won't read you the label, but it's very similar to the inclusion criteria of COAPT. They looked at the data between COAPT and MITRA-FR, and they couldn't find any subgroup within COAPT that did not benefit. The ACC-AHI valve guidelines recently came out, and for COAPT type patients gave a 2A guideline with level of evidence B. You might say, well, with such overwhelming level of evidence, why is it not class 1? And the guidelines committee just couldn't figure out all the differences between COAPT and Mitra FR. But as long as we keep enrolling patients with less severe MR or greater comorbidities, we're not going to show differences. So you have to really be careful in your patient selection criteria. Nonetheless, all the valve treatment pathways now say, this most recent one from Bob Banau, that yes, if you have heart failure and you have symptomatic secondary MR, and basically you're maxed out on guideline-directed medical therapy and remain symptomatic, that TMVR with the MitraClip is indicated. And finally, after a long wait, we received reimbursement from the United States government. So that's when you know that they think something works. When the government's actually willing to pay for it, that's the last thing that ever happens. And so now that has occurred. So in the bottom line is that COAPT and Mitra FR provide complementary guidance for patient selection, demonstrating which patients with heart failure and secondary MR are likely to benefit and which are unlikely to benefit. And we equally don't want to treat patients who are not going to benefit. The FDA is approved and guidelines support the MitraClip for patients with heart failure and secondary MR meeting COAPT criteria. Strict reliance on those criteria should allow duplication of the COAPT results in the real world and avoid overtreatment. And ongoing and future trials investigating surgical and transcatheter mitral valve repair and replacement techniques and devices in patients with heart failure and secondary MR who meet COAPT criteria should include the MitraClip as an active control arm. So if we go back to the original Carpentier classification, who are those candidates? Well, if we look at primary MR with appropriate clinical and echocardiographic indications, it's still mainly patients at high surgical risk, although those at intermediate surgical risk, I think, are very ripe for potential treatment. And again, the repair MR is very important ongoing for that trial. If we look at secondary MR, it's really those patients who are symptomatic with severe MR, despite maximally tolerated guideline-directed medical therapy with a left ventricular end systolic dimension less than or equal to 7 centimeters. But there's a lot of other patients. That's, probably no more than 10 or 15% of all the FMR. What about patients with 2+ or 2.5+ MR whose ventricles aren't dilated at all? What about patients not on maximally tolerated guideline-directed medical therapy? What about stage D shock patients, higher or lower left ventricular ejection fractions, atrial secondary mitral regurgitation? There's still a lot of questions for which we need a lot of other studies. And there's also a lot of different devices that are being developed, either edge-to-edge techniques, in particular the Pascal device, which I think will be very complementary to the MitraClip. There may be some cases where one will be better than the other. We'll have to find that out. There's direct and indirect annuloplasty devices. And of course, there's a whole host of transcatheter mitral valve replacement devices which promise to more effectively eliminate mitral regurgitation. And the procedures may actually even be simpler once they become transeptal. But of course, the sizing, the fixation, paravalvular leak issues, left ventricular outflow tract obstruction issues, the need for anticoagulation, and potential thrombosis. We've got a lot of concerns, so we've got to really figure out where these are going to fit in. And then there's a whole host of other very interesting approaches that are, again, trying to all duplicate what the cardiac surgeon does so well. So it always comes back to that. So I think we've made the first major steps in the transcatheter treatment of mitral regurgitation, both for primary and secondary mitral regurgitation. We got a long way to go, but I'd say that the future is very bright. Thanks very much.
Thank you, Gregg. Any comments? That was a fabulous talk, by the way, as well. Any comments or questions from anybody? I have one. So Gregg, I say I'm 65 and I have aortic stenosis, and I have some functional MR. Say it's grade 3. And what are your general thoughts about this? I mean, am I reasonable to think I'll just treat the aortic stenosis with the TAVR, and when my MR gets worse, maybe I'll have a clip? Do you want to just comment on these sorts of patients?
Yeah, there has been emerging data about that. You would think that perhaps when you reduce the left ventricular outflow tract obstruction, the functional MR will reduce, especially if you don't have LV dilatation, if you've got mainly hypertrophied ventricle. And it does in maybe about 1/3 of the cases. So unless you have really torrential secondary MR, and I think in most cases, if you've got severe aortic stenosis, it's worth doing the TAVR first and seeing what happens to the secondary MR. But then if the secondary MR, after several months does not resolve, or if the patient remains still tremendously symptomatic, now where you can put on perhaps better medical therapies because you've relieved the aortic stenosis, then the MitraClip would definitely be appropriate.
Any other comments from the panel? Yeah, please.
So Gregg, a fabulous talk again. So in the Mitral FR data set, right? So are there any patients, because their ventricles are bigger and so forth, that you actually reduce the MR too much? The old concept of, the MR is actually helping you sort of survive a bit with a little bit unloading. Would that be such a sort of patient population that they too far beyond that actually maybe just a bit of MR reduction, but not too much? Our new devices are so good that we could bring MR to basically almost zero, right? So is there sort of the other spectrum that maybe we should not do as much in some of the patients that are on the other end of your picture, right? The dilated ventricle type.
Well, I can tell you, I've spoken to a lot of surgeons about this concept. And of course, mitral regurgitation reduces afterload. You fix the MR, you now increase the afterload. And the concern is if you have a terrible ventricle, that you can overwhelm the capacity, for the ventricle to eject blood. Surgeons are very mixed on whether or not that phenomenon even exists. People like Mike Mack think it doesn't exist. Other surgeons think that it might exist. But if it does exist, it's probably only for patients kind of near shock, ejection fraction 5 to 10%, blood pressure's 80, who then you can't get them off the pump if you totally eliminate the mitral regurgitation. For most part, the patients that we're treating who are non-shock, have bad heart failure, but non-shock, I don't think that's a concern, given where you are in the Starling curve. And also, of course, the MitraClip usually doesn't totally eliminate mitral regurgitation. So I think it's gradual enough, and we rarely see people hemodynamically deteriorate right after you put the MitraClip in. That's pretty uncommon.
So I had a question for both Gregg and Marty, actually, which relates to the challenge of catheter-based techniques and evaluating them relative to surgery, but just in general, when there are multiple etiologies. I mean, one of the challenges we have in our clinical trial designs is that we're typically only evaluating one device at a time. And I think, a lot of people have speculated for a long time that there may be roles for multi-device combinations, annuloplasty devices plus a clip, mitral plus tricuspid going at the same time. How are we going to get those kinds of data? How are we going to allow for multi-device intervention, which in the United States, right now would be heroically expensive? How can we get there?
How we can get there? That's the difficult part of the question. But you're absolutely right. Perhaps it's not as much an issue on the aortic side unless there's secondary valvular involvement. But when you have mitral valve disease and you often have pulmonary hypertension and you often have tricuspid regurgitation and you often have right ventricular failure, fixing the left side of the heart, it appears, does not have dramatic effects on what's happened on the right side of the heart. You may reduce pulmonary pressure somewhat over time. The TR doesn't seem that it goes away all that much, especially when it's profound or torrential. So on the mitral side itself, there's a role for combination therapies. For example, if the leaflets are too far apart, you can't clip them, use an annuloplasty device. Bring them closer. If that doesn't work, or if you have recurrent MR, then you can clip. Obviously, a valve might fix all of that. Then you might need to approach the tricuspid separately. So there's clearly a role for these multimodality devices, but you're right, they're very expensive. The clinical trial pathways are almost inconceivable. So I think the first thing we're going to do is just focus on one problem at a time, trying to do what we did in COAPT, which is isolate the disease to that valve that we're trying to fix. saying that's the predominant cause of the patient's symptoms, so we can see an effect from just fixing that one issue, and then go on to the next. But maybe Marty has more insight into this problem.
No, I think that it's an interesting area. I mean, we tried to approach this a little bit with the Watch TAVR study. This is the AS of the AS plus AF situation, where we actually did, try to do a combination versus single device therapy, and we'll see what those results are. But that was an interesting approach. We had a lot of issues with CMS and reimbursement, and so there were a lot of logistic and economic issues to overcome. But I think that was an attempt to try to address that kind of question. We also designed an interesting, mitral trial, which, was stopped for other reasons. It was a Carillon device, which is an indirect annuloplasty device, and incorporated in the trial design was a 6-month evaluation to try to discern whether or not the patient was responsive or not. And if the patient was not responsive, they were allowed to have MitraClip at 6 months, to look at sequential therapy in non-responders incorporated within the clinical trial design. So I actually think that that's an interesting approach to how we can do this in the future, as long as one of the devices is approved, like MitraClip was approved. I actually think that that's a possibility on the tricuspid side. You might want to start with an annuloplasty device, and if that isn't sufficient, you might want to, then consider edge-to-edge repair and incorporate that into a sequential trial design. So it's fascinating, and I think that we'll start seeing studies like that in the coming years.
Well, guys, I think we're getting pretty close to time up, and this is a good time for us to all go about our business. I'd like to thank Dr. Park for having us all here.
All right, so I'm really honest with you. I'm very happy and honored to have you all two top speakers in the world in the different topics. I really learned a lot from you two, and I really thank you, Debbie and John. In practical point of view, I just a simple question to Mary. In TAVR concern in Korea, we are a little bit generalized in procedures, and how, especially for the bicuspid aortic valve, still many operators really prefer self-expanding evolute R device rather than the SS3 something else. Is there any data or preference of your opinion for that?
Well, first, SJ, it's always great to join you. You know how much we love you and how much we wish we could be with you. So next year, we hope we're going to be in Seoul right by your side. You have typically asked one of the more controversial questions. I mean, John and I are more balloon expandable guys. And we would defend to the death that a short balloon expandable frame device would achieve similar results in bicuspids. But there are no randomized trials, and there are some ideas that would favor one or the other in bicuspid disease. I can make an argument for using either in certain patients. So rather than try to give you a categorical answer, I would say that both devices, at least in registries, have shown pretty good results. And I think that in certain anatomies, you might prefer one or the other. That's my politically correct approach.
We could spend another hour or days talking about this, but thank you very much to everybody, and have a good day.
Thank you.
Bye now.
Thanks.
Thank you.
Thanks, everyone.
Bye. Great.